Good afternoon, everyone. I am Arpita from the IGCP group. It gives me immense pleasure to welcome our speaker for today's session, Dr. Jayakar Thomas, sir, a distinguished name in the field of dermatology, to today's session on the topic psoriasis, a systemic disease. Dr. Thomas is a professor and head of the Department of Dermatology and Venereology at Balaji Medical University, Chennai. He holds multiple prestigious qualifications, including MD, DD, MNA, PhD, FAAD, FIAD, FIAP, and FRCP from Edinburgh, Glasgow, London, and Ireland, as well as an FRCPCH. With a career spanning several decades, Dr. Thomas has made remarkable contributions to clinical dermatology, research, and academic mentorship. His work has been instrumental in shaping the understanding of dermatological disorders as systemic conditions with wide-ranging implication on overall health. In today's talk, Sir will shed light on psoriasis as more than just a skin condition, emphasizing its systemic nature, its association with comorbidities such as metabolic syndrome, cardiovascular disease, and arthritis, and the importance of a holistic management approach. We are honored to have him with us today to share his deep insights and vast clinical experience on this vital subject. Please join me in warmly welcoming Sir. So with this introduction, I would now request you to please start with the topic, sir.
Thank you very much, Arpita, for those nice words of introduction. Of course, we know that we are doing this presentation today to commemorate the World Psoriasis Day, which actually is tomorrow, the 29th of October. But most dermatologists, at least people like me who do a lot of presentation, are all the time busy with so many other things that we can't do everything on one day. That's why I requested IJCP to keep it a day earlier so that we could finish it off today. Now, I'm going to talk about psoriasis, not just as a cutaneous disease. Most of us always believe that psoriasis is only a skin disease, but it is more than skin deep, my dear friends. And for that, I have a few relevant presenting points this afternoon to all of you. So, starting off with a very good afternoon to all of you, I have to tell you that I have some information about myself alone, which has already been told by Arpita. I believe I have no conflict of interest and none to declare at all, and no financial relationship exists with commercial interest in this presentation. I would request the audience to refrain from photography and to also understand that all the information in my lecture is the proprietary and sole property of the lecturer and is not to be reproduced in any fashion without my written permission. To start off the day, psoriasis, just like your herpes progenitalis, that is cold sores, one of the most stigmatized skin disorders. Survey has shown that it's such a big stigmatized disorder. Also, studies have shown that psoriasis severity predicts vascular disease risk. Young patients, particularly vulnerable to life threatening complications, and we shall see down the presentation what are the different vulnerable complications and that too life threatening complications that could occur in patients with psoriasis, particularly the younger ones. Now, in 2010, the Journal of Investigative Dermatology has reported that psoriasis and systemic inflammatory disease, potential mechanistic links between skin disease and comorbid conditions. So, we will discuss that for the next few minutes. What is the mechanistic link between so many systemic comorbs as well as psoriasis? And talking about these links brings us to the very simple and basic fact that psoriasis is now classified as an immune mediated inflammatory disease, IMID, immune mediated inflammatory disease of the skin. Patients with Various IMIDs are at high risk of developing systemic comorbidities, and IMIDs may impact these comorbid conditions through shared genomic environmental factors or common inflammatory pathways that are co-expressed in IMIDs and the target organs, meaning connecting the skin from the skin as well as to so many other conditions that, or rather, so many other organs that we keep talking about. Let's see where we are going now from here. What is the missing link? Psoriasis. We are aware of so many systemic diseases, but what is the missing link? Here we are. Here we are. The genomes, genes rule, my dear friends, genes rule. Immune pathways, particularly the T helper 1, Th1, and then environmental factors, which I would like to call as epigenetic factors. Genomic genetic factors, immunological factors, and epigenetic factors, which I shall elaborate upon a few minutes from now. Apart from that, the inner circle by drugs, stress, and insulin resistance. Isn't that peculiar that we start talking about all of a sudden dropping from the air is insulin resistance, and we'll see how. We'll see how. I told you genes rule. It has been shown that 9 chromosomal loci are associated with psoriasis, and these are named as SOR S1 to SOR S9. SOR S1, 2, 3, 4, 5, 6, 7, 8, 9. Of which SOR S4 is likely to be involved in terminal differentiation of keratinocytes. In other words, we know about the keratinocytes, particularly those which are present in the stratum corneum. Unless they differentiate to form the normal cells, we do not get a normal skin pattern. Because that is affected here, we get psoriasis. And how does that happen? Now, the incidence of psoriasis is high among people who have affected relatives. That's again because of the genes ruling. Twin studies have shown that monozygotic twins have a 2 to 3 times higher risk of developing psoriasis than dizygotic twins. So, obviously, it comes to a final conclusion that genomes or genetic factors definitely play a great role. But we should not forget the epigenetic factors also, which I shall talk about later, as I told you. Now, there's high significant susceptibility locus on chromosome 16q, approximately 20 centimeters from the NO2 gene. Now, this is a little bit high, maybe for GPs who are here, and if you're not, even for dermatologists, a little bit high. But it's worthwhile knowing. And an important fact is that there is a co-localization of atopic dermatitis and psoriasis loci, meaning that both psoriasis and atopic dermatitis march to become systemic disorders, and a definite connection between these two disorders. And look at the shared genetic risk factors that we are talking about. We have psoriasis on one end, we have obesity, both of them interrelated, one leading to the other. Obesity to psoriasis, psoriasis to obesity, and both leading to cardiovascular disease, which is the most life threatening problem that we are all worried about when we're dealing with patients with psoriasis. Now, when it comes to psoriasis with children, this is just an example to show how a brother and a sister, where genomes have played a role, a mother and a child. Now, here is an example what I told you about co-localization of psoriasis and atopic dermatitis. Here is a boy with atopic dermatitis and at the same time having psoriasis. The combination of both diseases in one person is not uncommon, although there are many dermatologists in different parts of the world who may not agree. But it is a fact, and there is documented facts about both occurring at the same point. Now, here is the father. Here is the father who's having psoriasis of the palms and the child having atopic dermatitis. And even when we did a biopsy, the hand clearly showed psoriasis histology, whereas the child showed a dermatitis histology with vascularization. Now, what about, we said first genomic, now immunological factors. Immunological factors, a number of them, Th1, Th17, Th22, all known to be prototypical of inflammatory diseases, and T cell activation, again, is controlled by an extensive array of dendritic antigen presenting cells, which I shall just give you a brief idea towards the end of my presentation. Now, these dendritic cells in psoriasis produce high levels of IL-23, interleukin 23, and they strongly stimulate T cell proliferation. Interleukin 23 strongly stimulating T cell proliferation. With these facts in mind, we can definitely look at cardiovascular disease being linked to increased expression of specific interleukins. And what are those interleukins? We have two forms of them, my dear friends, the ones which are not good and those which are not bad. Those which are bad or not good are pro-atherogenic or pro-inflammatory cytokines. Pro-inflammatory cytokines, including what we spoke about in the previous slide. Whereas the good cytokines will include normal leptin function, adiponectin, interleukin 10. Potentially, most of the other cytokines, which are protective cytokines and anti inflammatory. So we have two groups, the pro inflammatory and the anti inflammatory, which lead towards cardiovascular disease. Apart from that, environmental factors, which I would certainly want to call as surrogate factors, stress, infections, drugs, obesity, smoking, alcohol. Alcohol is a very, very important thing. Smoking and alcohol, one thing that we should discourage our psoriatic patients from indulging in, because the rest of it is all something which we can bring under control. But this smoking and alcoholism is in the patient's hands. We said there are a lot of systemic manifestations. What are them? Some of them are mentioned here. This is a very modest list, my dear friends. Arthritis, diabetes. I'll tell you how it is becoming a comorbid condition. Hypertension, cardiovascular disease, which we just saw with the cytokines. Chronic obstructive pulmonary disease. Metabolic syndrome. Bowel and celiac diseases, which are well known to occur. Your regional ileitis, autoimmune and collagen vascular diseases, although not very common but do occur. Malignancies, good number of malignancies are known to occur with multi-organ failure and psychological disorders. Here is an example. Here is an example where the patient was treated for surgical intervention, and along the line of surgery or along the line of sutures, the patient has developed psoriasis, meaning that here a CAPD has been done, and at the line of the surgical trauma, he has developed psoriasis. Case of psoriasis, again, the same patient which we saw earlier, when a coronary artery bypass has been done, following which at the 8 times. Then obesity with bulky individuals are known to have, particularly with the mid abdominal obesity. You see so many of them developing such severe forms of psoriasis. Abdominal obesity alone is enough. Alcoholic liver disease. Now, this is something which is very, very, it can be non alcoholic fatty liver disease and it can be alcoholic fatty liver disease. So, both could occur. But what is important for one to understand here is that again, liver disease and psoriasis have got the same genetic backing, same genetic background also. Hepatitis C virus is known to be associated, as you see here, hypothyroid states, chronic kidney disease following diabetes. And how diabetes comes in, we have still not talked about that. We'll see in a short while. Severe psoriasis in diabetes, depression in a child leading on to psoriasis. Now, this in chart is immunopathogenesis. It may not be very relevant to all the listeners here, but it starts off with the genes, gene expression, genetic heterogeneity on several genetic loci. As I told you earlier, the transduction, that is, signals from the corneocytes and dendritic cells. And then comes the cell receptor expression. Once the signals have been sent, cell receptor expression, followed by cell chemokine release. Number of cytokines and chemokines, particularly all the growth factors. And the growth factors are responsible for the thickening and retention of the multi layers of psoriasis. And that would increase the number of corneocytes, leading to perpetuation of the disease. So that is how the cycle takes place. But along with that, as I told you earlier, the surrogate factors of smoking, hypertension, obesity, and alcoholism should be kept in mind, because we cannot break the cycle, but at least we can break the surrogate factors. You can break the surrogate factors and make the cycle less severe, less severe. That's why I put up that. So now, my dear friends, we are not sure whether psoriasis causes other disease or that these other diseases cause psoriasis. So let's look at it a little deeper. But the fact that an association exists at all is critically important in treating psoriasis patients. Once we understand that, we are very successful in the treatment. And look at this. Psoriasis leading on to systemic inflammation, insulin resistance, and therefore diabetes mellitus, along with obesity, psoriasis, with all these taking place, leptin, resistant, P selection, vascular endothelial growth factor, all that growth related inflammatory factor, all increase insulin resistance, leading on to endothelial dysfunction. What you expect to see in anybody with diabetes mellitus. So psoriasis could lead on to that. And here are the different cutaneous manifestations that could be associated with psoriasis itself. And to continue from here, we see that this endothelial dysfunction that we saw earlier, we saw endothelial dysfunction here, and you see that the endothelial dysfunction leads to atherosclerosis, adhesion molecules increase, leukocyte extravasation, coronary artery calcification, myocardial infarction, and that is it, my dear friends, that we have to be very, very cautious about. The rest of it are all due to hyperandrogenic states, as we say. When we get these type of cardiovascular disease along with hyperandrogenic states, we always think of the metabolic syndrome. And here is what was important in the presentation. The cytokines in psoriasis, interleukin 1, 17, then tumor necrosis factor, acting on the adipose tissue, leading on to endocrine dysfunction. That by itself could be a cause for the diabetes. Acting on the muscle, impaired glucose disposal. Glucose is not disposed, so accumulates in the circulation. Again, diabetes. Effect on the pancreas, impaired beta cell function. Beta cell function is reduced, that is hypoinsulinemia, as a result of which, again, diabetes. And action on the liver, reduced suppression of glucose production. There's reduced suppression, so there is increase of glucose production, all of them paving pathway for the cause of diabetes. And now we are able to understand how psoriasis and diabetes could be conducted. But there is yet another thing, the march that we talk about so much, the psoriatic march. In psoriasis leads on to systemic inflammation, insulin resistance, which we saw in the previous slide, endothelial dysfunction, atherosclerosis, cardiovascular disease. This is to put it more in a nutshell. In a nutshell, how psoriasis and CVD are related. One thing, in spite of our best efforts, three important questions remain One is, can we predict who will be at risk at developing comorbidities? Yes, we can, but there are a lot of investigations and a lot of biochemical markers that we talk about. Will early intervention with therapy help prevent the onset of these comorbidities? Yes, yes, a big yes. Will these children with psoriasis grow to healthy adults? Depends on how we manage them, how we manage them. And we have done various studies. My colleagues and I have done various studies, and we have published it. Comorbid conditions associated with psoriasis, a study of comorbid conditions in psoriasis in different places that I worked and different colleagues of mine. And we have always made it a point to make sure that we publish all our findings. We publish all our findings. Study of childhood psoriasis. This was for the Department of Dermatology when I was working in Sri Balaji Medical College. I'm not there now. It was wrongly mentioned by Aprita that I am in Balaji Medical. I am currently in the Chettinad Institute of Medical Sciences, where here we studied. This is about 15 years back when we studied the comorbidities. We selected 90 patients and we saw that a high percentage of them are having comorbidities, and it seems to come when the duration is between 1 to 5 years. More than 5 years, it drops, it drops. More than 5 years, it drops. And it's worst seen in the forms of palmoplantar and chronic plaque psoriasis, which are the two common forms that we get to see. And the age incidence maximum is seen somewhere in the midlife, 41 to 50. So these are the vulnerable factors and factors that one has to be careful about when seeing patients with psoriasis, with hypertension, diabetes, ischemic heart disease, and obesity. Obesity is some of the findings. So factors influencing these comorbidities: age of onset of psoriasis, the duration of psoriasis, and the gender. The gender. Multiple studies again, which have been published by my colleagues and I, and where they've shown where psoriasis and atopic dermatitis can occur together as an immunological spin-off. And with all these studies, we have been able to come out with several books, and this is just one of them. Psoriasis, a closer look, closer look. So look beyond the skin, my dear friends. Look beyond the skin. And this is what I put up always in my clinic. That is a poster which says we have to do all this. So when a patient with psoriasis comes, tell them that this is all to be done. It's of course it's up to them to decide whether they want to do it or not, because much depends on the financial constraints also. This is issued in public interest. Lifestyle modification holds the key in combating progress of psoriatic disease, meaning exercise, diet, then the mindset against the disease. No, lifestyle modification holds the key in combating progress of psoriatic disease. And finally, my dear friends, all of us, you and I, we have the duty to see that every patient with psoriasis is helped to live his or her normal span of life in perfect health. That's why we have to know certain facts about psoriasis and get it translated on the health of the patient. Health of the patient, lifestyle modification, proper foods, good mindset. And of course, with all that, don't forget that apart from lifestyle, we also have to have our own style where we should be able to just chill it out and live comfortably with our friends and colleagues. Thank you very much, my dear friends. I wish I've been able to convey some useful information. Thank you. Thank you, Arpita.
Thank you, sir. Thank you so much. That was an outstanding presentation, I would say. Being a non-medical person, also, I could gather a lot of information. I had no idea that so many diseases are associated with psoriasis. Thank you, sir. Thank you so much.
Thank
With
you.
that
Thank
note,
you.
now, I would like to take the questions from our audience. Sir, the first question is, sir, in your experience, do most patients with psoriasis come to dermatologists first, or they are often referred after the systemic issues appear?
No, they come to the dermatologist first because the skin sign is the first to appear, and that's what is visible. Nobody knows that they're getting a block in the cut. Nobody knows that their
Correct.
arthritis is coming with it. So they come to the dermatologist first. That's why I said it is the responsibility of the dermatologist to refer the patient to the other specialist, not take on everything and say, I know everything, I know everything. I don't know anything. I know only about the skin. I must honestly confess that and send the patient to the respective specialist.
Right, sir. Sir, how do you like counsel such patients who discontinue treatment once the skin clears up, ignoring the systemic component of the disease?
That, my dear Arpita, is what we are facing. Because the moment the skin lesions go, as I told you, they come to you when there are skin lesions. And when the skin lesions go away, they just give up the treatment and then start getting the systemic complications. And then they come again and then becomes difficult. Very sorry.
Right, right, sir. Sir, given the rising use of biologics in India, what practical advice would you give clinicians on initiating and monitoring biologic therapy in real-world settings?
Number one is the financial affordability, because all these biologics are very, very expensive. Talk to the patient, counsel the patient, find out about the possibility of spending money on this. But let us come to the ground rule that it's not necessary that all of them have to be treated with biologics at all. Some of them could be treated with such fine drug. We have methotrexate, we have acitretin, we have cyclosporin, and now newer drugs are coming, the JAK inhibitors, and Premilast is there. So many drugs are coming in with which we should be able to manage. But then when we have to fall back on, for instance, if the patient is a chronic alcoholic and having alcoholic liver disease, we cannot use methotrexate, we cannot use acitretin, we cannot use cyclosporin, then we have to go to the biologics. Biologics is not the first choice. That's what I'm trying to say. It should not be kept as the first choice.
Right, sir. There is a similar question. In our setting where affordability and access are concerned, how do you select between conventional systemic drug and biologics? So, as sir has already mentioned, biologics should not be the first choice.
No,
And yes,
never.
the systemic method, so it's first, sir, select. Yes, sir. The next question is again on patient counseling. So many patients still view psoriasis as just a skin condition. How do you effectively communicate its systemic nature and the importance of lifestyle modification?
One thing is that big poster that I shared. Yeah, I shared, and I have my assistant to explain to the patient also, and I myself would explain to the patient. The importance with the year is to be willing to spend some time with the patient. Most people think that dermatologists are all doing spot consultation and spot diagnosis. Not so at all. It is not so at all. There's much more than that. Spend a little more time with it. If one says, "Oh, I don't have the time," then you should not be a dermatologist. Huh? When a physician can spend 15 to 20 minutes on each and every patient, why shouldn't the dermatologist spend, if not similar time, at least something closer to that? So time spent is important. Counseling is important.
Right, correct, sir. So, when a patient presents with both severe skin lesions and psoriatic arthritis, how do you prioritize therapy? Do you start with systemic agents or combine dermatological and rheumatologic management right away?
You have to combine. We have to combine. We cannot treat just one at a time. Particularly arthritis, something which can be sometimes, not always, sometimes crippling. Can be crippling. So make sure that we don't allow it to progress. Make use of that also.
So, in your practice, do you make any dietary changes in psoriatic patients? Any lifestyle modification that
Yes,
you
when it
suggest?
comes to lifestyle modification, make sure that low glycemic diet is taken because we know the diabetes is again linked to it. So low glycemic diet is very important apart from exercise.
Right, sir. One last query. In routine dermatology OPDs, what are the simplest and most cost-effective way to screen psoriasis patient for metabolic syndrome or cardiovascular risk?
We have to take into consideration the possibilities of all the symptoms and signs of metabolic syndrome, particularly hair loss, for example, acanthosis nigricans, obesity. These are some of the things that are associated factors with metabolic syndrome and also with psoriasis. That we have to tick off one at a time and make sure that we are doing the best for the patient.
Right, so these were all the questions for today. And yes, it's 3:30. We are going to end up. But before that, sir, I would like to thank you. Sir, your talk beautifully highlighted how psoriasis extends far beyond the skin and emphasized its systematic implications and, of course, the importance of multidisciplinary management, as you have mentioned, and the need for early screening of the associated comorbidities. So, sir, thank you so much. The practical guidance that you have shared with us today, I'm very sure that it will be helping many clinicians who have joined today's session. So thank you so much, sir, once again for
Welcome,
joining.
Arpita,
Thank
and I
you.
also thank you and Dr. KK for giving me this wonderful opportunity. As usual, IJCP gives me a lot of opportunities to address the general practitioners, and I'm glad for that. And I'll certainly be happy to do it again and again. Take care,
Sure, sir.
all of you. Bye.